And our next speaker also needs no introduction. Dr. Laura Collins from Weill Cornell Medicine, New York Presbyterian, USA. Her topic is Contemporary Considerations of Breast Core Needle Biopsy. Please welcome Dr. Collins.
Good morning, everybody, and I'd also like to thank the organizers for the invitation, the honor of the invitation to speak to you all this morning. It's a great privilege. So I'll be talking about core needle biopsy, and you'll actually notice some themes running through, I think, today's sessions as we sort of reiterate and reinforce some points about pitfalls as we're going through and mimics. So for my talk, I'd like to talk about, to begin with, talk about contemporary patient management and breast core needle biopsy. So with higher resolution imaging, this has allowed us to detect smaller lesions. We also see the use of larger gauge needles and vacuum assistance providing greater sampling and perhaps even complete removal of the lesion. We have better radiology pathologic correlation happening because we've got access, often have access to the digital images. And also, I think you'll be well aware of a trend toward de-escalation of therapy, at least on the malignant side, and I think that's crossing over for benign lesions also. So all of this, combined with newer, better data, management has become much more conservative. And also, as Dr. Brogi mentioned, there are fewer opportunities for that second look to check your diagnosis if patients are receiving decisions based on the core needle biopsy. So in terms of correlation and concordance, with mass lesions, we tend to think of, obviously, carcinomas, but fibroepithelial lesions can be the explanation for mass-forming lesions. For calcifications, we have DCIS and low-grade invasive carcinomas, sclerosing adenosis, and fibroadenomas. Architectural distortion, of course, again, invasive carcinoma comes in here, but also benign sclerosing lesions. And for non-mass enhancing MRI-detected lesions, there are many, many correlates for that, including many benign things such as pseudoangiomatous stromal hyperplasia, apocrine cysts, but also carcinomas in situ and invasive carcinomas. So the pathologic diagnosis on a core biopsy must be concordant with the imaging, with the impression from imaging studies. And, you know, the onus is squarely on the radiologist to sort of finalize that benign concordant or discordant kind of finding. But I think it's also incumbent on us as pathologists to know what the history, imaging findings, and differential diagnostic considerations are in order for us to do a thorough evaluation. And any discordant diagnoses must be reconciled, and this may require repeat core biopsies or surgical excision. And this can all be facilitated by regular radiology pathology correlation conferences. So as far as management problems, the issues have been that the literature consists of small, single institution, often retrospective studies, many lacking clear criteria for which patients underwent excision versus follow-up, and often with selection bias and very short lengths of follow-up. There's often lack of clear radiology pathology correlation, with many of the upgraded cases having imaging features that warranted excision in the first place. As well, we need to remember that the criteria for atypical ductal hyperplasia were established on open biopsies and not the limited material afforded by core needle biopsy. And upgrade rates are variably defined. Some people include atypias in their upgrade rates. Other people restrict it to carcinomas in situ and invasive carcinomas. So that's why we have this very broad range of defined upgrade rates. And finally, the definition of high-risk lesion varies by discipline. So oncologists think of high-risk lesions as those that confer an increase in subsequent breast cancer risk, such as atypical ductal hyperplasia, lobular carcinoma in situ, DCIS, whereas radiologists tend to think of high-risk lesions as anything that confers an upgrade in the immediate excision period. So the upgrades rates associated with complex sclerosing lesion, for example, or the upgrade rates associated with atypical ductal hyperplasia. So what I want to talk about is review some of the newer literature with better data that helps us sort of strive toward fewer excisions for our patients with some of these benign lesions. And this will include this list of topics just here. So let's begin with lobular neoplasia. The long-standing practice for LCIS and atypical lobular hyperplasia on core needle biopsy is that surgical excision is needed to exclude a worse lesion, that is DCIS or invasive carcinoma. And historically, upgrade rates reported have ranged from 0 to up to about 33%. But classic LCIS and atypical lobular hyperplasia is usually an incidental finding with no associated imaging target. And in fact, more contemporary studies with careful radiologic pathologic correlation demonstrate very low upgrade rates when classic lobular neoplasia is determined to be incidental to the imaging target and of the order of about 2%. So current practice has evolved such that truly incidental classic LCIS or ALH do not require surgical excisions. And upgrades, when they do occur in the very few cases, usually are of small, low-grade invasive carcinomas that are probably incidental in and of themselves. I will say that image-detected LCIS, that is LCIS associated with calcifications, does still require excision. There's really insufficient data on non-classic or variant forms of LCIS, such as florid LCIS and pleomorphic LCIS, which are more often associated with, with an imaging target due to their association with microcalcifications. Recent reports indicate upgrade rates of about 20 to 50% for pleomorphic LCIS and florid LCIS diagnosed on core needle biopsy. And, you know, I need to have the caveat that these are usually very small numbers of patients in these studies, but nonetheless, that just reinforces the point that these patients should undergo excision. And excision is warranted, and I would, suggest use of E-cadherin and P120 in this situation to help separate DCIS from LCIS as a differential diagnostic consideration. And certainly you don't want to be diagnosing these cases as just LCIS without a qualifier if there are some variant non-classic features. So here's just one case in point where we can see these very expanded spaces filled with an epithelial proliferation and necrosis. And, at low power, this could very easily look like DCIS. But in fact, the E-cadherin was negative, and here's one P120 stain showing cytoplasmic expression of P120 with a membranous internal control over here. Moving now to intraductal papilloma. Here, the issues of concern really revolve around sampling issues, because we know that benign papillomas can harbor foci of atypia, or DCIS. And distinction between benign, atypical, and malignant papillary lesions is difficult for all of us, especially with limited material. I think this is a little bit of a less of a concern today with more awareness, larger gauge needles, access to immunohistochemistry, and consultation when needed. And so you'll see with newer data, and this is a systematic review and meta-analysis of 13 studies evaluating the upgrade rate on excision for patients with benign, concordant intraductal papillomas. And the pooled upgrade rate to malignancy is 1.4%. So that's very low, and that's an acceptable upgrade rate such that patients with intraductal papilloma diagnosed on core needle biopsy that's concordant, as in there's no concerning features on the imaging studies, don't require excision. There are some factors that have been reported to be associated with upgrades, higher rates of upgrade, and these include concurrent ipsilateral carcinoma, if the specimen fragments, although I would say that many of these papillary lesions, the specimen fragments, symptomatic presentation, that is nipple discharge, palpable lesions, peripheral location, those patients sometimes are more, it's more prudent to recommend excision. But the carcinomas, again, when seen, are often small incidental carcinomas, and that can be nicely illustrated by this paper from the Memorial Group, where we see the benign intraductal papilloma on core needle biopsy here, and here in the excision, again, benign intraductal papilloma here, and then sort of remote from the lesion really is a small invasive lobular carcinoma. So our current practice is referral to surgical nurse practitioner or surgeon for targeted imaging targeted papillomas, and then referral to surgeon for consideration for excision for patients that are symptomatic. but certainly no excision for incidental papillomas that are seen on core needle biopsy. Moving now to mucocele-like lesions, here the reported upgrade rates to DCIS or invasive carcinoma historically have ranged up to 30%, but again were encumbered by small numbers in the studies, not all patients undergoing excision, so there's selection bias, and often these studies have included mucocele-like lesions with and without atypia. So, the concern here is if you have a core needle biopsy just with pools of mucin and, no epithelium to guide you, so this could be a mucocele-like lesion or it could be a hypocellular mucinous carcinoma. And indeed, one of the other cores in this particular case showed atypical epithelial cells floating in these pools of mucin. So this, in fact, was a mucinous carcinoma. So in terms of current practice, excision is certainly required if there's pathologic radiologic discordance or any atypia seen on the core biopsy, but excision is not required if the findings are unequivocally those of a mucocele-like lesion without atypia and if it's RAD-path concordant. You might want to do additional levels to rule out mucinous carcinoma in these cases, just to be certain. Moving now to radial scar and complex sclerosing lesions. The challenge here is that these lesions can mimic carcinoma clinically, radiologically, and pathologically. There are some imaging features that favor radial scar. For example, if there's this sort of lucent center or greater extension of the arms, the sort of stellate features. Pathologically, we look for sort of that lobular-centric pattern, elastotic stroma. Those things would favor a benign process. But often immunohistochemistry is needed to highlight a myoepithelial cell layer. But be aware that reduction in staining has been reported, and this is from an earlier paper by our group, where you see a complex sclerosing lesion here, and here some immunostains showing reduction of expression with smooth muscle myosin heavy chain. So the issues of concern are that distinction from invasive carcinoma can be quite difficult, especially with limited material. And, I think why we get worried about these is that in the radiology literature, there seems to be a sort of higher incidence of adjacent invasive carcinomas reported in the radiology literature, which is why our colleagues in radiology are always a little bit squeamish about these lesions. But current data does support observation for radial scars. So here's a nice example of a radial scar. You can see this sort of elastotic stroma here, and the benign epithelial elements kind of radiating out from the center. Another example, here the sort of entrapped glands in the center of these elastotic stroma and benign epithelial elements radiating out. Another example here with this very sort of fibrotic stroma, entrapped glands. And this case actually was misclassified as an invasive carcinoma. And you can see why that might be. But you have to be very careful. If there's ever pink stroma, fibrotic stroma, or elastotic stroma, think about benign lesions first, rule them out before leaping to invasion. And in fact, I think you can even see the myoepithelial cell layer here. And this looks like a very heterogeneous epithelial cell population. Contrast that with this, where you do have a very few sort of small glands, kind of more in a haphazard arrangement and not really this sort of central kind of nidus as such. So this is a small tubular carcinoma. Here, again, another radial scar, similar sort of entrapped glands, but these elements radiating out. So you really have the architecture, which may not be as easy to appreciate on a core biopsy, of course, depending how the needle goes through the lesion. Here, contrasting with a tubular carcinoma where you have more haphazard arrangement of the glands, they're infiltrating out beyond any central nidus that you might be imagining. As well, there is epithelial atypia in the intraductal or in situ component. Another pitfall for sort of sclerosing lesions is if there's carcinoma in situ involving a benign sclerosing lesion, that can sort of compound the sort of distortion that you might get with a sclerosing lesion with monotonous epithelial proliferation, as this example illustrates with LCIS in a tubular adenosis. You can see the monotonous epithelial cells, and it's hard sometimes to appreciate the myoepithelial cells because they can be quite attenuated. So then you might use a myoepithelial, a couple of myoepithelial cell stains just to make sure that that layer is present. This is a recent meta-analysis, a fairly recent meta-analysis, looking at upgrade rates of over 3,000 radial scars after core needle biopsy. And you can see when there's no atypia in the radial scar using vacuum-assisted biopsies that there is an upgrade rate of just 1%. So again, our current management really has evolved such that we don't need to excise these lesions as long as they're radiologically, pathologically concordant. However, if there's any atypia, excision is recommended. Finally, atypical ductal hyperplasia on core needle biopsy. This does still require excision to exclude carcinoma because of higher upgrade rates. So upgrade to a worse lesion can be related to things like technical factors such as how large a gauge needle you've used, whether the lesion targeted were calcifications or a mass. If it's a mass, it's more likely to have an upgrade. Completeness of removal. If all the calcs are removed, then you're less likely to have upgrade to carcinoma. And then pathologic factors such as how much ADH is present and whether it's sort of micropapillary ADH, those things can be indicators of whether the lesion will upgrade. There are some institutions that do have sort of like a tumor board for atypical ductal hyperplasia, where there are criteria that the tumor board will look at to see if more than 50% of the calcs are removed, if there's no mass, if there are fewer than 3 foci of ADH on the core biopsy, and certainly no necrosis. And when that's the situation, or when patients don't meet those criteria and go on to excision, the upgrade rate is around the sort of standard reported rate of around 20%. And with a median follow-up of 3 years, those that did not undergo surgery, the patients that met criteria, the upgrade rate was just 5.6%, or the carcinoma rate was just 5.6% at 3 years. So only a personal history of breast cancer was associated with subsequent breast cancer events with a hazard ratio of 12.5. So I would say in terms of atypical ductal hyperplasia, we are getting closer to identifying a subset of patients with ADH on core who can safely be spared excision through the use of larger gauge needles, multiple cores that might remove all the calcifications, limited ADH on histology. And certainly it's important to remember that we now have watchful waiting studies for patients with DCIS, so it makes sense that we should be striving to identify patients with atypical ductal hyperplasia on core who may not require excision. However, the current recommendation is for patients to undergo excision. And this is just a summary table of the upgrade rates, of contemporary upgrade rates on core needle biopsy for DCIS and invasive carcinoma. A few years ago, the management of benign papillomas really varied considerably in terms of who was doing what for their patients. Some people, a majority still excising, some having short follow-up, some returning to normal screening. And for radial scars, many more were undergoing excision. But I think it's evolving. You can see from this study, from a similar time point, the recommendation for surveillance over 2 different time points, so 2007 to 15 and 2016 to 2017, there was a much greater likelihood for recommending surveillance rather than excision. So how do we avoid getting ourselves into trouble? I think you need to be aware of the imaging findings and the radiologist's differential diagnosis. Multidisciplinary conferences can help with appropriate triage of patients. I advise liberal use of levels, but judicious use of immunostains. I don't think you want blanket immunostains because that can get you into trouble. And be conservative, avoid overdiagnosis when findings are equivocal, and re-review triple-negative breast cancers. And so I'll touch on that a little bit. But just to talk about potential pitfalls in a little bit more detail. So, with benign epithelial proliferations, the mimics are carcinomas, of course. So radial scars versus invasive carcinomas, I've talked about. UDH versus DCIS, intermediate nuclear grade, I think is challenging. Papillary lesions, a whole topic in and of itself. And DCIS versus LCIS, which I touched on already. Dr. Brogy has talked about triple-negative breast cancers, and I think Dr. Wen will also talk about it, so I won't go into that too much detail. Spindle cell lesions as well. There'll be a slide seminar on that later on. And then that's the differential of metaplastic carcinomas versus benign spindle cell lesions, which again, we already heard about a little bit. I'll talk about displaced epithelium and just reiterate a few points about metastases. So here is a lesion that, could easily be interpreted as DCIS or even invasive carcinoma. You've got very distorted nests of epithelial cells, this funny-looking cellular fibrotic stroma. And I think, you've got to try and remember that there are benign processes for which sclerosing processes can happen. And if you look, you've got sort of these slit-like spaces, and if you then examine the cells on higher power, you can see they're very heterogeneous looking. There are some intranuclear inclusions, maybe some nuclear grooves in places. And so this is usual ductal hyperplasia, not DCIS. Contrast that with this example, where again, I think you have sort of this streaming of the nuclei, which could be, we think of for usual ductal hyperplasia. But there is, even though the nuclei are more oval, which we think of for UDH, and streaming, which we think of for UDH, I think there is a monotony and a similarity to the nuclear features of these cells. The polarization around spaces can be a little bit less dramatic in intermediate nuclear grade DCIS, so that can be more subtle. But I think there's a little bit here. What I find very helpful, in addition to sort of the monotony of the nuclear features and chromatin, is the presence of apoptosis. I think if you start to see apoptotic debris around and about, I would do CK56 and ER stains just to rule in or rule out UDH and DCIS. So here's a CK56 stain highlighting the myoepithelial cell layer, but negative in the epithelium, and the ER will be strongly and diffusely positive in atypical proliferations. So when you're trying to discriminate invasive versus benign lesions, you're going to use your myoepithelial cell markers, but when you're trying to discriminate atypia versus benign, you're going to use ER and CK56, which are both heterogeneously positive in UDH and strongly and diffusely positive for ER in DCIS and negative for CK56. Triple stains can also be helpful because you'll have the myoepithelial cell layer in brown, both nuclear and cytoplasmic, and then both pink and brown for low and high molecular weight keratins in usual ductal hyperplasia. This is another case where I think one could be mistaken and fall into a trap of invasive carcinomas. We've got this sort of fibrotic stroma, distorted and irregular nests of epithelial cells, and even some necrosis here. But I think if you look carefully at the epithelial proliferation, it looks very heterogeneous. We've got slit-like spaces, variable nuclei, and even probably a myoepithelial cell layer here. So even if you have necrosis, I think you still need to think about usual ductal hyperplasia. The original pathologist did a P63 stain, and unfortunately still somehow interpreted this as invasive. And I think, you need to remember that P63 is a nuclear stain, so you're going to have loss of or absence of nuclei in your plane of section in some areas. The saving grace should have been the ER stain. So this shows heterogeneous expression, which is more in keeping with usual ductal hyperplasia. So that can be a useful safety check. Triple negative tumors, you've already really sort of heard about this. Here are our special subtypes. I just want to touch on one triple negative or potentially triple negative tumor that can be a pitfall. So here is a case that was called invasive ductal carcinoma grade 2. You can see why that might be. We've got solid nests of rather monotonous looking epithelial cells and this funny sort of mixoidy, maybe desmoplastic looking stroma. It turned out to be ER, PR, and HER2 negative, which actually shouldn't be for a monotonous looking grade 2 invasive ductal carcinoma. So it turned out this was an older lady with a large palpable breast mass, and if you actually look on low power, you can see it's got this sort of lobulated appearance. And you have to think of adenomyoepithelioma in this situation. I think if you don't think about it, you're going to fall into this trap yourself. And so we revised the diagnosis to adenomyoepithelioma, and it was excised, and you can then see that there's, P63 staining or smooth muscle myosin heavy chain staining highlighting the myoepithelial cells. And I bring up this pitfall because we actually looked at it, led by Dr. Quintana in my prior group, looked at 41 adenomyoepitheliomas upon excision, and of 29 cases that were non-atypical on excision, fully 20% of them had been called carcinoma. So it is a pitfall that you actually just really need to think about, I think. If you don't think about the diagnosis, you yourself may fall into that trap. And so you have this lobulated lesion of epithelial and myoepithelial cells that can have many different appearances. I think that's the other pitfall. It can have lots of different appearances. We don't see them very often, and so that's why they can be problematic. Just touch on a couple of high-grade triple-negative cancers. You've heard about all the pitfalls already, just to illustrate how similar carcinomas and epithelioid angiosarcomas can look. And these can be very readily mistaken for mammary carcinoma, as these case reports show. Spindle cell lesions, the varieties are lesion, and here's just a table or a list for your handout that shows all the different spindle cell lesions, those that have bland spindle cells, those that have atypical spindle cells. And I think the point here is that you always need to rule out metaplastic carcinoma in these cases. Want to just remind you about displaced epithelium. So this is the situation that occurs post-core needle biopsy, right? So most patients who have excisions nowadays have already had fine needle aspirations or core needle biopsies. And so you'll have situations, here's a benign intraductal papilloma, and here is a sort of cellular stromal area with some epithelial cells. And it doesn't have that lobular-centric arrangement. They look very haphazard. They look kind of atypical. And so, again, if you're not thinking about the possibility of displaced epithelium, you can make a mistake. And certainly if you do immunostains, that will reinforce that mistake, because here you see lots of single keratin-positive cells, no p63 staining, and so that might reinforce your impression of invasive carcinoma. Here's a fairly recent case of a core needle biopsy of a targeted mass, and you can see there's this sort of sclerotic area here. There is a little bit of epithelial proliferation, which I think has slit-like spaces and kind of a heterogeneous appearance. This institution routinely did immunostains for things like this. So here's the ER and CK56. And you can see that it has a heterogeneous pattern of expression, so really should be called usual ductal hyperplasia. It was called atypical. I think, the patient underwent excision, which may have been fine. It was a sclerosing lesion. There was some discordance. And so here is the sclerosing lesion. But there were these epithelial elements here in this very cellular stroma, and looks a bit atypical. They did a keratin and p63 cocktail, and you can see no p63 staining. So this was actually called invasive ductal carcinoma. It went to the edge of the specimen, so the patient had a re-excision and a sentinel lymph node biopsy. So it's really, really important to, think about displaced epithelium, recognize that, biopsy site stroma, and it's not, desmoplasia. Think of the possibility, look for invasion away from the biopsy site, and look for a recognized type of invasive cancer. And for LVI, certainly be extremely conservative if there's only DCIS or a benign lesion, and look for LVI away from the biopsy site. Just in closing, talk about other high-risk situations. So I think in the era of neoadjuvant therapy, as Dr. Brogi touched on, it's particularly important to review the H&E slide at the time of receptor sign-out, especially for triple-negative cancers. You want to confirm that the morphology is consistent with breast carcinoma, ensure there's no prior history of another carcinoma, and consider further workup if the findings are atypical or in the setting of a history of a prior cancer. So here's our typical classic triple-negative breast cancer, sheets of high-grade tumor cells, areas of necrosis. And here's a mastectomy from a patient that had been diagnosed with triple-negative breast cancer, received neoadjuvant chemotherapy. And you can see sheets of high-grade tumor cells, no evidence of any response to the chemotherapy. There's sort of a different-looking area up here, which I'll get to. On higher power, you can see large pleomorphic cells, areas of necrosis, and I think very easily to diagnose this as triple-negative breast cancer. I can see myself doing the same. There was this area here with slightly sort of, a bit more abundant cytoplasm, a little bit grayish looking, and the pathologist who received the mastectomy specimen thought this was a little bit unusual looking, was concerned about the lack of any response, because triple-negative breast carcinomas actually do respond quite well to chemotherapy, and looked into the history, and the patient actually had a history of melanoma. So metastatic melanoma to the breast is something that can happen. So as was already said, don't forget that not all cancers in the breast are breast cancer. Consider this when the morphology is atypical. If there's no in situ component, although triple-negative breast carcinomas often don't have an in situ component, or the core biopsy may not actually go through that. Any history of other cancers, any triple-negative cancers. We heard about the malignancies metastatic to the breast. We heard about the markers that you should use. And remember that the absence doesn't exclude a breast carcinoma. So I'll just close with this final example of a papillary carcinoma present in the breast. So papillary carcinomas occur in the breast, right? Not infrequently. This one's a little bit unusual because it's got high-grade morphology. That's not to say that can't occur, but it's a little bit unusual to have mitoses, in high-grade nuclear morphology. So the pathologist did a workup, CK7, CK20, ER, GCDFP, and mammoglobin at the time. And, this is still consistent with breast, right? Even because we know GCDFP and mammoglobin can be focal or even absent in breast tumors. But often the best ancillary test is actually to compare with the prior, right? So this patient did have an ovarian primary, looks pretty similar to our breast core needle biopsy. And in fact, when you did a WT1 stain, it confirmed metastatic serous carcinoma of ovarian origin. So your final safety check really is to ensure that receptor status is concordant with the H&E findings. ER negative or low positive tumors are usually high grade. You want to be accurate with your percent positivity because patients with less than 10% ER positivity are often eligible for triple negative therapies or trials. So be accurate. Don't just say, oh, it's about 15%. And ensure low-grade tumors are strongly and diffusely positive or that they're of a special histologic subtype. So you need to know the expected biomarker profiles for your special histologic subtypes. Also, be careful with HER2, right? So HER2 3+ tumors should be high-grade or of apocrine morphology, because FISH is not mandated for those 3+ tumors. And so you want to be careful with actually not just 3+ and 2+ anymore, but also 0, 0+, and 1+. So you want to ensure that the morphology is compatible. Review, consider further IAC workup if findings are unusual, receptor status is discordant in the setting of a history of another cancer. So to summarize, I hope that you've appreciated that I've shared some of the common and uncommonly encountered diagnostic challenges in breast tumor pathology. I hope I've helped how to anticipate and avoid diagnostic pitfalls and shared some morphologic clues and ancillary testing strategies that can support diagnostic interpretation and help prevent errors. And also, I think so important to remember that the risks are so much greater with core needle biopsy, especially today in the era of neoadjuvant systemic therapy. And with that, I thank you.
Thank you very much, Dr. Collins, for giving out a practical way of approach core needle biopsy. And I believe this can save us from many future headaches. And this time, it's time for a question. Are there any questions?
Yes.
How often do you see squamous metaplasia within displaced epithelium, and how do you approach it?
Yeah, so the question, squamous metaplasia in displaced epithelium. I think very often it can look kind of squamoid, right? I wouldn't say full-on squamous metaplasia is seen that often, although certainly it can be seen in biopsy site. So yeah, how do you approach it? I think what I was saying is basically kind of look at that low power look. It's got this kind of diffuse look in the biopsy site. So if it's in the biopsy site, I think you can attribute it to displaced epithelium, and whether or not it's got squamous metaplasia is sort of, not consequential in terms of management. If you're worried about metaplastic carcinoma, then you want to look away from the biopsy site, right? So, for example, benign sclerosing lesions can have rarely, there can be metaplastic carcinoma arise in that situation, but you'd want to be sure you're looking well away from the biopsy site for that.
Thank you.
I have one follow-up question from that question.
Mm-hmm.
If you see adenosquamous nest in the core biopsy, would you mention it?
So adenosquamous nests in the core biopsy. This is like a very, not a common challenge, but a common discussion when we encounter that challenge, is sort of what to do about adenosquamous nests in, what otherwise would be a complex sclerosing lesion or a radial scar. And it's hard because, So you're thinking about low-grade adenosquamous carcinoma as the differential diagnostic consideration, and that's hard even on an excision specimen, right, to render the diagnosis. So on a core biopsy, where you can't really necessarily tell whether those nests are infiltrating out and beyond, because that's what I would use on excision, is are the nests infiltrating out and beyond any of the benign components that you can readily recognize. So you can look for cytologic atypia. I think if you have that, that's helpful, and I would mention it. I wouldn't call it adenosquamous carcinoma on a core biopsy, but I think that I would say that there are nests of concern and excision recommended for full evaluation, and then just sort of appraise it in that situation. But yeah, that's a challenge that we have regular conversations about when we encounter it.
Thank you. And thank you so much, Dr. Collins.
Thank you.